Respiratory distress syndrome is a sudden and progressive acute lung failure characterized by increase in permeability of alveolar capillary membrane. Here you can see this is the alveolar capillary membrane, the alveolar epithelial lining, the alveolar type 1, type 2 epithelial cells, the endothelial lining, and the intervening interstitium. There is inflammatory edema due to which the patient will have dyspnea and hypoxemia with bilateral lung infiltrates. This is a definition of ARDS. The Berlin definition of ARDS states that the origin of edema, the inflammatory edema, should not be of cardiac origin, and it should not be due to cardiac overload, and the cardiac failure should be ruled out by echo. So the origin of edema should be purely due to pulmonary damage and due to increase in permeability of alveolar capillary membrane. The timing, the ARDS symptoms should occur within 1 week of known clinical insult or new or worsening respiratory symptom. The chest X-ray should show bilateral opacity in the absence of lung collapse and pleural effusion. The oxygenation should be impaired. Obviously, when there is inflammatory edema in the pulmonary system, when there is inflammatory edema, the exudates inside the alveoli, it causes ventilation perfusion mismatch, causing reduced oxygenation in the body. So, if we take PaO2 to FiO2 ratio, PaO2 is partial pressure of O2 in the arterial blood vessel, the oxygen saturation in the arterial blood vessel, and FiO2, the fraction of air inhaled, that is 21%, we all know that, 0.21. The ratio of these two, the PaO2 normal value is between 75 to 100 mmHg, and FiO2 is 0.21, the ratio of which should be normally between 400 to 500 mmHg. It is called as mild ARDS when the PaO2 to FiO2 ratio is between 200 to 300 mmHg. It is called as moderate ARDS if it's between 100 to 200 mmHg. It's called as severe ARDS if it is less than 100 mmHg. This is about the Berlin definition of ARDS, acute respiratory distress syndrome. Let's see the etiophysiology of this condition, acute respiratory distress syndrome. The etiology cause can be due to direct lung injury, where there is primary pathology involving the lung, or can be due to indirect lung injury, which is secondary to other causes like anaphylaxis, the sepsis, acute pancreatitis, etc. The direct lung injury can be due to pneumonia, which can be bacterial or viral pneumonia, and due to aspiration of gastric contents, which can be due to many other secondary causes. And the blunt trauma to the lung causing lung contusion is one of the cause for ARDS due to direct lung injury. And under indirect lung injury, we have anaphylaxis as one of the cause, where intake of certain drugs, bee and wasp sting, will cause widespread release of histamine and other inflammatory mediators, which is causing the increased capillary permeability along with hypotension. So due to increased permeability, there will be inflammatory edema causing ARDS, anaphylaxis. We have fracture, the fracture of shaft or other fractures, multiple fractures leading on to fat embolism. The fat embolism will cause ARDS. The intake of overdose of certain drugs like barbiturates and opioids. This will cause the reduced central drive for respiration. And then we have inflammation, where the septic shock and acute pancreatitis will cause ARDS. In septic shock, due to the release of inflammatory mediators, interleukins and cytokines, there will be the ARDS. In acute pancreatitis, due to phospholipase A2 and due to other inflammatory mediators, increased permeability will lead on to ARDS. Now, coming to pathophysiology of this condition, we have exudative phase, which is seen between 1 to 7 days, proliferative phase seen between 3 to 7 days, and fibrotic stage seen between 10 to 14 days after the injury, primary insult. In exudative phase, following the primary insult, there will be inflammation involving alveolar epithelium and capillary endothelium. This inflammation will cause the exudation, the leakage of proteins into the alveoli. The leaked proteins and cellular debris inside the alveoli will form hyaline membrane inside the alveoli. There will be increased level of cytokines and interleukins, which are produced by these inflammatory cells, neutrophils and macrophages. This causes increased further recruitment of neutrophils. So the interleukins 1 and 6 and TNF alpha will cause further recruitment and again the inflammation. This inflammatory exudates inside the alveoli will obviously cause ventilation perfusion mismatch. So there will be hypoxemia in these patients. In this proliferative phase, the proliferative phase name is derived from proliferation of type 1 and type 2 alveolar cells from progenitor type 2 alveolar cells. This is during the repair process. The proliferative phase occurs between 3 to 7 days, where the exudates which are formed due to leaked proteins and cellular debris get organized, and also the type 2 alveolar cells which produce surfactant along with the they act as progenitor cells. They'll form the type 1 and type 2 alveolar cells, replacing the damaged epithelial cells. Then we have the fibroblast proliferation, which forms the connective tissue. This is about proliferative phase, followed by that in some patients with severe ARDS, and if the patient has ongoing insult, they go on to develop fibrotic stage, which is seen after 10 to 14 days of primary insult, where there is widespread fibroblast proliferation and laying of fibrotic material, which causes interstitial lung disease in these patients. This is about the etiopathophysiology of ARDS, acute respiratory distress syndrome. Coming to clinical manifestation of this condition, the patient will have rapid onset of dyspnea. We know the reason. Then the patient will have hypoxemia due to ventilation perfusion mismatch. Due to this hypoxemia, the peripheral and central chemoreceptors will get activated, causing tachypnea and then tachycardia. And then due to reduced oxygenation, increase in reduced hemoglobin will cause cyanosis in these patients. The features of primary insult of ARDS can be seen. The features of sepsis, the cold extremities, hypotension, or the features of acute pancreatitis like epigastric pain and tender abdomen, tender distended abdomen can be seen. These are the features of the diseases which causes secondary lung insult. Then on auscultation, we see bilateral crepitations due to inflammatory exudates inside the alveoli. Then we'll go on to investigations. On chest X-ray, we see diffuse bilateral infiltrates. You can notice the diffuse bilateral infiltrates in the lungs. On doing arterial blood gas examination, there will be marked hypoxemia. The PaO2, the partial presence of O2, will be less than 60 mmHg in the arterial blood. The PaO2 to FiO2 ratio will be reduced and it will be less than 300 mmHg. I explained about PaO2 and FiO2 initially. To rule out cardiogenic origin of pulmonary edema, we should do echo, 2D echo, to look out for the ejection fraction and all. And we can estimate plasma brain natriuretic peptide, which will be increased in case of cardiogenic edema. Then coming to treatment, first we should identify the precipitating factor which is causing ARDS and treat it accordingly. Treat the sepsis, acute pancreatitis, treat the fracture and all adequately. Then we should manage the hypoxemia in this patient. That we will manage by endotracheal intubation and positive pressure mechanical ventilation. In mechanical ventilation, we should maintain the positive end expiratory pressure and supplemental O2 at an amount and at a level to achieve SPO to the saturation of O2 more than 90. Then the patient can be placed in prone position so that the atelectatic alveoli will open. This is about management of hypoxemia. Fluid management. In primary ARDS due to aspiration or pneumonia, we should do fluid restriction. In secondary ARDS like sepsis and anaphylaxis, we already have the hypotension due to shock. Then in these cases, we should give fluid and potent vasoactive drug like epinephrine or epinephrine dobutamine. This is about ARDS. To summarize, acute respiratory distress syndrome is a sudden progressive acute lung failure, alveolar capillary membrane permeability, inflammatory edema causing dyspnea and hypoxemia with bilateral infiltrates. The Berlin definition states that the origin of edema should not be cardiogenic and the timing should be within 1 week of known clinical insult, new or worsening respiratory symptom. Chest X-ray should show bilateral opacity with ruling out lung collapse and effusion. And oxygenation, PaO2 to FiO2 ratio in mild ARDS is between 200 to 300 mmHg. In moderate is between 100 to 200 mmHg. In severe ARDS, it's less than 100 to 100 mmHg. Coming to etiopathophysiology of this condition, we have etiology as direct lung injury and indirect lung injury due to pneumonia, aspiration, lung contusion, anaphylaxis, fracture causing fat embolism, acute pancreatitis, septic shock, barbiturates, and opioid overdose. Then we have pathophysiology of this condition, 3 stages: exudative phase, proliferative phase, fibrotic stage. In exudative phase, there will be marked inflammatory response and inflammatory edema inside the alveoli. In proliferative phase, there will be repair process taking place. The type 2 alveolar cells will proliferate to form type 1 and type 2 alveolar cells, and there will be exudation organization. In fibrotic stage, there will be, which is seen in only some patients with severe and ongoing respiratory insult, where there will be marked fibroblast proliferation, which causes interstitial lung disease. The clinical manifestations are rapid onset dyspnea with hypoxemia, tachypnea, tachycardia, cyanosis with features of primary insult of ARDS like sepsis causing cold extremity hypotension. On auscultation, we see bilateral crepitations. Coming to management investigation, we perform chest X-ray where we see diffuse bilateral infiltrates. On doing arterial blood gas examination, there will be marked hypoxemia, PaO2 less than 60 mmHg, PaO2 to FiO2 ratio less than 300 mmHg, and to rule out cardiac origin, we do echo and plasma BNP levels. Under treatment, we have identification of precipitating factor and treating it, and management of hypoxemia by endotracheal intubation and positive airway mechanical ventilation to maintain SpO2 more than 90. And then fluid management. In primary RDS, we restrict the fluid. In secondary RDS, we give fluid with potent vasoactive drug. This is all about acute respiratory distress syndrome. So, thank you for listening.